Next talk is by Dr. H K Chopra. He is going to speak on Clinico-echo SGLT2 navigation in HFpEF. Where are we today? All of you know Dr. Chopra is the Chief of Cardiology at Wilshire Medicity Hospital, and he is editor-in-chief of many textbooks, which we see every year. And he is a great preventive cardiologist. Dr. Chopra, please.
Mr. Chairman, sir, fellow colleagues, ladies and gentlemen, it's really a great pleasure and honor indeed to be here on the occasion of Second World on Clinico-echo SGLT2 navigation in HFpEF. Where are we today? I think at the outset, I will pay my tribute to the pioneers of SGLT2 inhibitor trials all over the world. Dr. Anker from Germany, who was the pioneer for Emperor Preserved in October 2021, Dr. Butler, same time, and Dr. Nassif, preserved heart failure in October 21. Then we have Dr. Deepak Bhatt, who was in Solace trial and delivered 2021 by Solomon and Abraham on Imperial Preserve trial. They are the real pioneers who really educated us. SGLT2 inhibitors has come to stay, no doubt about it, safe, effective, and promising. Multi-system metabolic benefits are known to us. That's a good news. And it's a cardio, vaso, and nephroprotective. Reduce hospitalization with heart failure, severity of heart failure, worsening, reduce morbidity and mortality. Useful both in diabetics or no diabetic, hypertension or no hypertension, AF or no AF, congestion or no congestion. The most important potential of SGLT2 inhibitor is it's a osmotic diuretic, anti-diabetic, anti-inflammatory, anti-fibrotic, and reverse remodeling. Lot of data is emerging on reversal of remodeling. Morphological, functional, hemodynamic, biomarkers, biochemical, hematological, and cell reprogramming, including the reduction of leptin levels. Used with beta blockers, RNA, MRA, and device therapy, including RDN and LAN. What's the bad news? The bad news is there's a rising trend of HFpEF the whole globe. It's a multi-system disease, not confined to only heart, and not to be used when the eGFR is less than 20, and especially in patients with ketoacidosis or the recurrent fungal infection, and not to be used in type 1 diabetes, pregnancy, or malignancy. What is the main agenda of my presentation? The main agenda is to highlight the burden, mechanism, diagnostic, prognostic, and therapeutic implications, and morbidity and mortality reduction, and discuss the problems and solutions. Definition is very well known to you. Ladies and gentlemen, I must say less than 40%, 41 to 49%, and 50%. But a new modality is coming up now. We are seeing a lot of patients who are remodeled or reverse remodeled. They are coming with a heart failure with an improved ejection fraction or even normal ejection fraction. So what is the classification or the criteria? Already Dr. Naveen Nanda has spoken, but I must tell you, we use echo morphological as a very powerful criteria in our practice, where we see LAVI more than 34 as a major criteria, and LAVI 29 to 34 millimeter per meter square as the minor criteria. And we use the functional criteria as E by E prime ratio of more than 15, and the GLS less than 16, or E by E prime ratio of 9 to 14 as a minor criteria. We also use sometimes other parameters like LV mass index or the relative alveolar thickness, and the biomarkers are very important, especially NT-proBNP 220 in the patients who are without atrial fibrillation, and 3 times more when a patient has got atrial fibrillation. This is a global scenario. I think we all know it. 10% of people beyond the age of 70 are suffering from heart failure. In heart failure with preserved ejection fraction, the women are more as compared to men. And we see here the comorbidity in the form of hypertension as number 1, atrial fibrillation, anemia, diabetes, CKD, and obesity. I think the global scenario is very clear that HFpEF is rising. Why in diabetics and hypertensive we see more HFpEF? Because of the hyperglycemia, cytokines, and activation of renin and aldosterone system. Calcium homeostasis is altered, mitochondrial dysfunction leading to LVH and diastolic dysfunction, systolic dysfunction, and heart failure. The pathology physiology is very well known to you. It is a loading in the heart, whether systolic overload or diastolic overload. And this equation of pressure and volume should be very well clear to all of us. This slide is showing a very clear cut. The ventricular component, the atrial component, autonomic function component, vascular stiffness, elevated blood pressure and diabetes, aging, obesity, and sarcolemma and sarcopenia, and especially lung disease or iron deficiency anemia are the major factors. And if you see the pathological specimen, we see a dilated heart and reduced ejection fraction, normal, and with preserved ejection fraction, we see a hypertrophied heart. Increased stiffness and hemodynamic variability in the form of increased filling pressures, including the aortic stiffness, is a very, very important parameter. The clinical outcomes are very clear that there is a high mortality in the patient of HFpEF, much more than reduced ejection fraction, which is a very, very important point. And it's very important to show that the people who are diabetics and hypertensives, they have more mortality and high morbidity. And the data is very clear from CHARM study showing that the HFpEF is definitely higher so far as the mortality is concerned. And again, from the Paragon trial, it is also very clear that the readmission rate and the mortality is higher with the HFpEF. Later on, if you see here in 2012, when data published, global data showing the mortality is much higher with HFpEF as compared to HFrEF. And we see here the Trivandrum study from our own country. It has also shown that the readmission rate is higher with HFpEF as compared to HFrEF. And the same Trivandrum study has also shown that the mortality is definitely higher. How do we diagnose? You already heard Dr. Naveen Siddhanda, but what we do practically in our patients in our lab, as the patient comes, we subject our patient to the echo evaluation and NT-proBNP. This is one of our patients who came in emergency, 48-year-old male, female, hypertensive and diabetic with a BP of 200 by 110. And we see here the sugar was 180 and see the echo variables. LAVI was very high and we see LV mass index was high and the patient has LV ejection fraction which was normal, tropi negative and NT-proBNP was 9,000. And see the echo of this patient, significant concentric LVH in long axis and short axis. And the same thing is revealed here. This patient also had a mitral annulus thickness and thickness of the aortic valve. So sometimes the HFpEF also presents with other comorbidities should be considered. 3D echo showing the increased LV mass index, a patient of aortic stenosis. And we see here E by prime ratio of more than 18.9. LAVI is a very, very important parameter which we consider in every patient. And I think very well expressed by Naveen also. More than 34 milliliter per meter square is the criteria. This is the prognostic, diagnostic, and therapeutic implications of the cutoff point of 34. LS strain, LS stiffness index is a new parameter which we always consider. We divide the LA into 6 components. Incremental value for LA dysfunction, very, very important. It has got a lot of implication, diagnostic, prognostic, and therapeutic implications. This patient showed a reduction in the LS strain and see the prognostic markers. All the patients who have a reduction in the LS strain are more prone to go into atrial fibrillation. LS stiffness index is another non-invasive LS stiffness index, E by prime ratio upon LS strain. If it is more than 1.1, it has a very high sensitivity and specificity. LV strain is also important. As we have seen here, the minor criteria, there is a reduction of the global LV strain and not the radial or the other LV strains like circumferential strains, which is also very, very important, especially in HFpEF. NT-proBNP, I think is also mentioned. The class of recommendation is 1 and evidence is 1. This is the whole textbook of cardiology and heart failure, which was published by Naveen, myself, and my colleagues in India. And it has shown all the parameters. Now in 2012, if you see the treatment of heart failure with preserved ejection fraction, there was no benefits, only diuretics. Even the morbidity benefit and mortality benefits were question marked. And see the data. I-preserve, PEP-CHF, CHARM, seniors, and DIG showed no benefit. And this is also to show Paragon study, Topicat, I-preserve, PEP-CHF, and CHARM preserved has shown no outcome benefit till 2020. Ladies and gentlemen, the treatment emerged only in 2021. SGLT2 inhibitor is a novel treatment of HFpEF. It is the real strategy we have to use in diabetics and non-diabetics, hypertensive or non-hypertensives, AF or no AF, and it's insulin independent. The total research period for this particular molecule is 90 years. It started in 1930 and we are practicing now in 2022. And where does it act is very well shown here. SGLT inhibitor reabsorption. This is the renal tubular glucose threshold variability, which is at the level of the afferent and the efferent vessels, has to be very well understood before we educate. This slide is showing the multiplicity of action. that SGLT2 inhibitor is anti-inflammatory, osmotic diuretic, anti-diabetic, anti-fibrotic, and reverse remodeling is a very, very important marker for making heart failure into a regressed heart failure or even a normal. And this is a very important slide which I have made myself for all my patients, that I consider reverse remodeling is morphological. It may act at the level of LA, LV, mitral annulus, aortic annulus, RV, RA, tricuspid annulus, and pulmonic valve, antifibrotic, improvement in the LA strain and global longitudinal strain, reduction of LVH and LV mass index, and improving the LV diastolic function and the weight loss. Hemodynamic variability is very important, which we always consider as E by prime ratio. Biomarkers already expressed. Biochemical, there is a reduction of uric acid and blood glucose. And the most important variability is cellular reprogramming and reduction of the hematocrit. And see any of the SGLT2 inhibitor, whether EMPA, DEPA, or CANA, or SOTA, or eritogliflozin, or ipragliflozin, reduce the MACE rate, hospitalization, and mortality, and even improvement in the renal functions. This is the evidence outcome benefit of almost 5 trials. I'm going to finish in 5 minutes. First is Soloist in 2021, Emperor Preserve trial in October 14, which is the landmark trial, and we see Deliver trial and Preserve heart failure trial. This is very clear by Soloist trial by Deepak Bhatt, who showed that there is definitely safety and efficacy of SGLT2 inhibitors, and hospitalization of the heart failure and urgent heart failure visit is reduced. But this data was inconclusive because of paucity of funds in the grant. In the study, it was mentioned there, so they could not show the details of benefits of mortality. This is very powerful data of Emperor trial, a landmark trial, phase 3 trial, 6,000 patients. Empagliflozin was given in doses of 10 milligrams. Composite primary endpoints in the form of CV death or hospitalization, and confirmatory key points were recurrent heart failure and slope of change in the eGFR is a very, very important marker. And the study was conducted over a period of 26 months. And see the data. Risk reduction of 21%, absolute risk reduction of 3.3%. And we see here, even if they studied the individual components of primary endpoints, CV death and hospitalizations, this drug was beneficial. And if you see the data on gender, male or female, age less than 70 or more than 70, and irrespective of a patient has got low ejection fraction or high ejection fraction or normal ejection fraction, diabetics or non-diabetics, patients were benefited. And here also we can see, irrespective of patient on any drugs, NT-proBNP high or low, comorbidity or no comorbidity, benefits were enormous. And we see here, this is a very, very important slide to show the secondary endpoints. They were all significantly reduced, and the risk reduction was 27% in the form of this eGFR improvement. As we see here very clearly that the slope of eGFR decline is slowed down in the patients with the SGLT2 inhibitors as compared to the placebo. And this is the data to show the specific confirmative endpoints, primary endpoints and secondary endpoints, and when the key secondary endpoint in the form of eGFR slope with a hazard ratio of 0.79 and 0.73, and p-value was very significant. So ladies and gentlemen, empagliflozin is very, very clearly outstanding as only molecule shown mortality and morbidity benefit in HFpEF. There is no doubt about it. And we see here another data by another study, which is the heart failure with preserved ejection fraction. We see here only functional benefit, no mortality benefit. Deliver data has yet to deliver in 2022. This is the 5-year mortality data. It has not come so far, but we are expecting improvement. And we see here functional benefit here, comparison of Paragon and Emperor, no mortality benefit, only seen with Emperor study. And if you compare with meta-analysis of 5 studies with 6,000 patients, Emperor preserved, Vertis, Declare, and Soloist scored is very, very clear. This is the European style, and they have shown very clearly that SGLT2 inhibitor is recommendation is 1, class 1A. This is an important slide which I prepared only yesterday. Who owns this molecule? Cardiologist, nephrologist, or endocrinologist? The answer is all. And the step should be step 1, beta blockers and SGLT2 inhibitor is number 1. After 2 weeks, step 2, RNA, and after 4 weeks, step 3 is MRA. Ladies and gentlemen, quadruple therapy saves life. Ask yourself, If no SGLT inhibitor, why not? It's very important. Rapid sequencing is important and not simultaneously if you really want better benefits and cost effective. Ladies and gentlemen, to conclude, India is the world capital of hypertension and HFpEF. Clinical echo guided management is the only way we can reduce the morbidity and mortality. And we see here the take-home message is health of millions is at stake with HFpEF in India. The problem of HFpEF cannot be solved can be solved only by rapid sequencing, and it can be a rapid game changers in the future. As Dr. Manoria mentioned, it may postpone the need of heart transplant and postpone the need of ICD. Time to act is now before it's too late. But there is a huge gap between the specialist and the primary physician. How we can handle it is the agenda. Thank you very much for your patient hearing, and I am very grateful to Dr. Mahapatra and Dr. Manoria for giving me the opportunity. Thank you.
Thank you, Dr. H K Chopra, for a lucid presentation. Nice.